I thank you all for being present. We have a great audience. It's a very popular audience, double that they had last year, so thank you very much for coming. We were talking about neurodegenerative disease and the impact of the blood and function. And after we start with the workshop, we have to I have to give some advice that please complete in the app evaluation of the workshop before leaving. We have several steps that are marked on the screen. First step is to go to the program of the day and to locate our workshop, and then you can scroll to find the evaluation button. Step 4 is complete the survey. That only take a few moments, but it will let us to improve our workshop as it did during the last year that we gave the same workshop. And for this year, we make some changes. I hope that they will improve the quality of the workshop. You have to know that hands-out for all workshops is available by the ICS app, also in USB sticks and in the website. So please silence your all mobile phones. And you have a PDF version of the slides also that are approved. My name is Christian Cobreros. I'm from Buenos Aires, Argentina. And I have the pleasure to be with professors who don't need any introduction, as Professor David Castro Diaz from Tenerife, Spain, Professor Carlos Levi d'Ancona from the University of Campinas of Brazil, and Professor Gustavo Garrido from University of Buenos Aires, Argentina, as well as mine. So as you see, we are all Spanish language talkers, so we are doing a great effort. So try to understand and try to be gentle with us, because it's rather difficult to make all the speeches in English, and it's getting difficult. So in any case, we can go back. So this is our first presentation. Would be a little complicated, because we have to put all the neurodegenerative disease in a way that put into a slice of 10 minutes. And the idea is to understand that all the neurodegenerative disease have same clinical features, that all the same, but with some difference that you may know, and you may have to take advance in the clinical presentation, and when you ask you be with the patient. This is my financial disclosures. I'm as a PI, I serve for different industry, but have no relation with this presentation whatsoever. So we do know, as starting with this workshop, that neurogenic low unit tract dysfunctions are one of the most challenging problems in urology, and the worldwide demographic aging is improving, that healthcare is improving. So as a matter of that, we have a lot of people that live longer and healthier lives. So, but the bad thing about this, as our population is getting older, as they are getting older, they have more neurodegenerative disease are getting more frequently. As you see, in this study by 2001, we have almost 24 million people with dementia all around the world, and with 5 million cases every year. So that turns that in 2040, we will have more than 80 million people with dementia living with us, and it will burden our economy and our medicine practice as well. And we do have to take care about this, because there's not the same relationship that we have in high-income countries that we are here, and with low-income countries that we belong, because it's different. Because in these high-income countries, the impact will be less than in low-income countries. And this is why. Because in high-income countries, they will have early diagnosis. And early diagnosis will be a principal factor for not going or not avoiding early institutionalization would be the more threatening condition for a patient with neurodegenerative disease. And in low-income countries, as we cannot get into early diagnosis, they get into urine incontinence get to institutionalization gets to get our resources of money to deal with the consequence of institutionalization. So probably infections, sequels, comorbid conditions, and we have so not much money to get into prevalence or to get to early diagnosis again. So low-income countries could be in a very high or huge problem. To get into a theme, we don't know that neurogenic low urinary tract dysfunction or LUTS of the urinary bladder and urethra will go through central or peripheral nervous system disease. The type of the dysfunction depends on the damage level, the extent and the intensity, as well as the time length of the specific disorder, maybe multiple sclerosis, Parkinson's disease, or any kind of dementia. But we have to take into account that neurological clinical presentations are not static conditions, that they may differ from time to time and in the same patient as well. So we have to deal with the possibility of confronting differences, clinical presentations, even in the same patients in different periods or in different scenarios. So neurological when LUTS dysfunctions may be part of another syndrome as well. As any kind of syndrome, as bladder outlet obstruction would be part of neurological urinary tract dysfunction, of altered behavior would be a part of a neurological low urinary tract dysfunction as well. And impaired attention, I don't see it very well, but I see here on the screen, impaired attention or motor disability could be, or even the treatment itself. The treatment itself, for example, the use of antimuscarinics could go against our patients. These clinical scenarios may all be combined together, so it's important to differentiate the symptoms in early stages. Now we're going to talk about Alzheimer's disease, and I put some combinations or confrontations with other kinds of dementia as white matter lesions or dementia with Lewy bodies. As we all know, Alzheimer's disease is the most common cause of dementia, as well as in Western countries is the most common cause of moving into a nursing home. One of the urological Alzheimer's disease presentation, it is overactive bladder, but it tends to be the overactive bladder increase their impact, but an impaired attention and orientation about producing reduced environmental self-awareness doesn't increase in the impact of our overactive bladder syndrome. And Alzheimer's disease also have this clinical presentation of urine incontinence, that urine incontinence in this disease is relationship also with advanced age, with deficits in attention, with reduced verbal fluency, with gait disorders, and with disinhibition. So urine incontinence in Alzheimer's disease is more than a consequence of a specific atrophy of an area of the brain related also with behavior as well, of course, that they have neurological or neurogenic diffuse overactivity as well. So the management in LUTS in Alzheimer's disease, it is difficult for several reasons. You get impaired attention and orientation, which interfere with the self-management of overactive bladder due to preventive voiding, double voiding, or inadequate response to urgency or urinary urgency. And antimuscarinic drugs may worsen the cognition and interact with acetylcholinesterase inhibitors, given to improve cognition and get the activity of daily living. So it is important also the time of the onset of the urine incontinence as well, because the time of the onset of urine incontinence is a marker of institutionalization, which is a predictor of a poor outcome. As you see, you can see the years of the urine incontinence onset in times after the dementia onset. In Alzheimer's disease, it's almost 5 to 7 years, while in dementia with Lewy bodies, it's almost 3 years. So urine incontinence seems to be more frequent in and have an earlier presentations in patients with dementia by vascular erosion. So urine incontinence is proposed as a marker of vascular dementia as well. Going to pathophysiology, we know that Alzheimer's disease is basically an atrophy of the cortex at the hippocampus. So it's more related, our urological presentations, with the cognitive decline and with the loss of initiative, with the impossibility of the patient to have a normal micturition, as well as we have also part of gait disturbance. But in another kind of dementia, as the Lewy bodies or white matter disease or white matter lesions, we do have two kinds of presentations by urine incontinence. The neurogenic detrusor overactivity, which turns into urine incontinence, and the gait disturbance by Parkinsonism. This is a fine article that correlates well the urinary, I'm sorry about that. It goes too far. But the urinary frequency, the nighttime frequency, and the urine incontinence in 3 populations, we have Alzheimer's disease plus white matter lesions and white matter lesions alone. So as you see, the worsened conditions or the worst clinical scenario you see in this, we see in white matter lesions, where you have more urine incontinence, more nighttime frequency, and more urine incontinence. But when they turn this population into urodynamic studies, hoping that they all have all of these have neurogenic detrusor overactivity, you see white matter lesions have the lowest percentage of neurogenic detrusor overactivity in urodynamic tests. So what it reflects that in another study shows that PET studies show that the frontal hypoperfusion is common in white matter lesions. So in white matter lesion, there is an alteration of the bladder circuit and determining a premature first decided to void, which leads to high urgency pattern and urine incontinence. So in some pathologies, brain images are essential to differentiate between 2 indications. So it turns us to, again, to the first we were talking at the first of the presentation. It comes to our principal point of this workshop, that is to get to early diagnosis. In terms of the second most common degenerative neurologic disorder is the Parkinson's disease, that we all well know. The net effect of the basal ganglia on the micturition reflex is inhibitory, so anything that alters as the presentation of the dopaminergic lesions in Parkinson's disease, which goes with the clinical presentation of neurogenic detrusor overactivity. And we all know that Parkinson's disease has motor symptoms and non-motor symptoms that are autonomic dysfunction as well. So the principal motor symptoms are related with the degeneration of the nigrostriatal dopaminergic neurons, while non-motor symptoms, they are autonomic, and one of the major problems in Parkinson's disease is nocturia. This is also this is the primary study. This is multi-center with more than 1,200 patients with Parkinson's disease, and they studied the impact on the quality of life of the patient with the Parkinson's disease, and you can see that non-motor symptoms have an increased correlation during the time of the disease and the severity of disease. As you see here, it comes to 90% with the severity scale of the disease in urinary symptoms. So Parkinson's disease may have motor symptoms as tremor, bradykinesia, or postural instability. But for the patients, it's really difficult to understand the relationship between the movement disorders that they have and the autonomic symptoms. So something very simple that you can do is to make a patient a blood diary. We all have print blood diaries to use for international continents, have their blood diary you can use too, and even do you have electronic blood diaries into the smartphone, they're really easy to use, that can determine and put the difference between a nocturia by overactive bladder and a nocturnal polyuria and altered bladder capacity versus an increase of nocturnal urine production in orthostatic hypotension, or maybe an increase in post-voidal residual due to oral treatment with antimuscarinics as a consequence of the treatment as well. So LUTs in Parkinson's disease may require a better understanding of the nature of the bladder symptoms and requires continuous reevaluation. Getting to another disease, this is multiple systemic atrophy, and the more important factors, there are here neurogenic detrusor overactivity is thought to be more important, even a make finding in MCI patients. Open bladder neck is almost a pathognomonic figure of the MCI patients. Incomplete bladder emptying is a significant feature in MCI patients as well, and the detrusor sphincter dyssynergia could be in 1/3 of patients. And you will see this again along in the workshop of another presentations. As in other basal ganglia disease, urinary symptoms precedes motor manifestation in multiple sclerosis atrophy. This means specifically in this disease, in multiple systemic atrophy, what we find is that the urinary symptoms and erectile dysfunction precede other motor manifestations for years before the onset of the motor symptoms. So this indicates that there are a lot of people that may seek urological advice early in the course of their disease. And we as urologists, or because we are urologists, but as doctors as well, maybe choose the opportunity to make the diagnosis because we are not aware or we are not listening quite well of the patient was saying to us. Then MCI, the clinical presentation get worse. It continued with a complex combination of urge incontinence, incomplete bladder emptying, that is presented here in the figure of this work, and the bladder capacity gets less. So this continence is further compromised by an open bladder neck, as you see before in the figure of Sakakibara, and weakness of a striated urethral sphincter. By the end, I have multiple sclerosis. All the pathways can be affected simultaneously or not. So there are a lot of variable symptoms and combinations of them that can be present in clinical presentations. And it's important to know that MRI findings could be present without a clinical significance, first of all, at the first stages of the disease, but they can turn into clinical significance during the disease. Urodynamic findings in this meta-analysis show that in multiple sclerosis, we do have three kind of presentations. The first one, which is almost the more frequently, which is detrusor overactivity. Then without outlet obstruction, then detrusor overactivity with outlet obstruction as a result of the detrusor sphincter dyssynergia and detrusor hypocontractility. So, of course, the most important and the most dangerous one is this one, the second one, that comes with an incomplete opening of the urethral striated sphincter at the same time that the patient have a detrusor overactivity, as well as it is a threatening condition. So, taking home messages for this brief presentation of the clinical presentations in neurological disease, may we find that clinical urological manifestations should not be taken as a unique manifestation. You have to take into account age, cognitive impairment, motor disability. Comorbid conditions should be considered for a proper diagnosis, and clinical urological findings can change over time due to changes in the neurological disorder. Urological manifestation as well can proceed other manifestation for years, so you have to be aware, and urodynamics assessment is necessary for detecting neurogenic detrusor overactivity with bladder outlet obstruction, as we said before, as it is a threatening condition. So, thank you very much. I think it takes a lot of time of this presentation, so we will continue with it.